I serve as the executive director for the Center for Genomic Sciences, and our primary mission is to understand how bacteria cause disease, specifically how bacteria cause chronic disease. We've been doing this type of research for nearly 20 years. We started at the University of Pittsburgh in 1990 and then moved to the Allegheny Singer Research Institute in 1997. Acute bacterial infections and chronic bacterial infections are very different. Acute bacterial infections are caused by planktonic bacteria, that is, bacteria that are swimming freely. Each bacteria is essentially a single-celled organism. Chronic infections, for the most part, are caused by bacterial biofilms, and the bacterial biofilm is, in essence, a multicellular organism, so that each individual bacteria within the biofilm is analogous to each individual cell in your body, and so that they are actually functioning as a single organism. And it's the adoption of the biofilm mode of growth that provides for what we say chronicity or persistence. And so when you get an acute infection anywhere in your body, when you have a medical device implanted, there is a finite risk that some of those planktonic bacteria that are associated with acute infection will land on the implanted medical device. And if they do, they can form a biofilm on that device, and then you end up with a chronic infection resulting from that. You can kind of think of bacteria as having a life cycle, because once the bacteria are on the device as a biofilm, there's always a certain percentage of the biofilm bacteria that are shed as planktonic bacteria. And we call these showers. And so when a shower of planktonic bacteria occurs, then that can cause an acute exacerbation. So you go from chronic to acute, chronic to acute. Now the acute you can treat with antibiotics. So you can treat somebody and you'll stop the acute infection, but you won't get rid of the nidus, the mother biofilm, which keeps spewing them out over time. And so that's why if you hear about somebody who has something like a central line or something like that, a catheter like in their vein, and they become episodically febrile, it means when they become febrile, they have a fever, that means they've had a planktonic shower. You treat the planktonic shower with antibiotics, then it kills the planktonic bacteria, but the mother biofilm stays intact. So they're no longer acutely ill, but they still have that chronic infection, and that chronic infection will produce subsequent showers again. So the only way to actually stop that showering is to take the device out, pull the catheter out, and start over again. There are two different ways, basically, that a medical device that's in someone's body can become infected. The first way is associated actually with the procedure that put the device in, so that there was a break in sterility. I mean, generally we try to do surgery under sterile conditions, but it's not perfect. And so at some low percentage, bacteria will be introduced into the wound site, at the time of infection. And so these are called, acute, again, infections, because it happens with the surgery. The second type is one where the infection occurs much later. It can occur years later when somebody has some sort of a what we call septic or bacteremic effect, where for some reason there's bacteria in the bloodstream. So for perhaps you had a dental procedure or something like that, and if you disrupt the biofilm bacteria, that are associated, with gum disease, it's very easy for them to get into the blood. So essentially, you have a planktonic shower, and then those planktonic bacteria, if some of them alight on, the plates in somebody's spine or their artificial, joint in their leg, then they can become they can have their implant infected years after it was put in. And so that those types of infections, those late occurring infections, are not because of a result in loss of sterility, during the surgical process. So basically, if somebody, is out more than, 6 months from the time of surgery, before they have any symptoms, then it's a fairly good guess that the infection occurred post-surgically as opposed to intraoperatively. Bacterial biofilms are very difficult for the body's immune system to get rid of, and that's why they can persist. The major difference between planktonic bacteria and a biofilm bacteria is that the biofilm bacteria are embedded in a matrix. So they actually produce a matrix that they're living inside of. So it's very analogous to our bone cells producing a bone matrix that they live inside. Okay? And so they're inside this matrix, and even if your body's immune cells can recognize the bacteria, they can't actually get to the bacteria because they're inside the matrix. In fact, a lot of the inflammation and a lot of the damage that's done for people who have biofilm infections is actually done by the host's own immune system inflammatory response, because it keeps trying to attack the biofilm and it can't do it very effectively. So it actually causes damage to its own tissue. This is actually what happens in cystic fibrosis. Cystic fibrosis, the fibrosis in the lung, doesn't occur because of the bacteria. It occurs because the neutrophils are continually trying to attack the biofilm, and instead they attack the host tissue. Bacterial biofilms can be monospecific, that is made up of a single species of bacteria. They can be polymicrobial, meaning they're made up of multiple bacterial species. They can also be polykingdom, where you have bacteria and fungi forming biofilms together. It is our belief now that the vast majority of chronic bacterial infections are biofilms. Whether we're talking about infections that occur on the respiratory mucosa, such as otitis media, which is the middle ear disease, the most common disease that children get, for which they have to see a doctor, for which they receive antibiotics, for which they have surgery. We have shown, I think, quite conclusively that this disease, middle ear disease or otitis media, is a biofilm disease. Similarly, we've shown that many other chronic bacterial infections of the respiratory mucosa, which includes, the lungs and the airways, are associated with biofilm infections. Some of the work we've done directly here, some in collaboration with our colleagues, but a short list of the diseases which we're fairly comfortable are associated with biofilms now in the respiratory tree would include adenoiditis, tonsillitis, chronic rhinosinusitis, certain forms of pneumonia, such as associated with cystic fibrosis, as we talked about earlier, and certainly a chronic obstructive pulmonary disease called COPD. One of the things that I would recommend to any patient who is going to have any sort of procedure done, if they already have an implantable device anywhere in their body, is that before the procedure is done, that they prophylactically take antibiotics to prevent, a planktonic shower, to prevent what we call bacteremia, which is simply bacteria in the blood. If you get a few bacteria in the blood, it doesn't necessarily mean you're going to be sick, but if you have a place for them to land, an artificial part in your body, then that can ultimately make you sick. So whereas I don't think that people should overdose with antibiotics, if you're going to have a procedure, okay, and you already have some sort of prosthetic device, then I think it's very wise, to be treated prophylactically with antibiotics before you have that procedure. That's one thing you could really do to cut down the risk, of developing a chronic biofilm infection. The other thing that I'd like, patients to know is that because there is now a community of scientists which recognize that chronic infections are associated with biofilms, and biofilms act profoundly differently than planktonic bacteria, is that it's only a matter of time before we do have effective therapies for biofilms.